Now we're going to talk about transplants and how they relate to the immune system. As you might imagine, transplants can create a problem because it's non-self. Unless you're going to do an autograft, you're going to have to face issues with your system recognizing non-self, which is a fundamental aspect of the immune system. So one of the first things that they do when they're looking at a transplant board, for example, is they look at HLA matching. So that's one of those straight away. If you implant a foreign organ into the body, it's going to essentially look at those HLA. Remember the MHC molecules. And as I said, these are conserved in the species, and some of us share the same MHC molecules. And so they typically look for this certain combination of a 6-for-6 match. And that's about as good as it gets in terms of being able to have a positive transplant. And that's part of the decision as to who gets this particular liver or kidney and who doesn't. If you got a pretty decent match, then that's a good thing, and that improves your chances. And so they tend to err towards that side and give that person the organ. The other aspect that they do is they obviously look at, your blood typing, because that's, we think about type A and B and O and all that, but there's several different antigens on your blood that are also a factor when you're talking about, transplant, because sometimes we obviously transfuse blood as well. So there's different stages. If you do get a transplant and you reject the transplant, there's different stages at which you start to see a rejection. And the first stage is hyperacute. So essentially this happens in the operating room. The surgeon connects up this new organ to the vasculature, and straight away it starts to necrose, looks gray, and it's like, somebody didn't do their homework, right? Because there were preformed antigen antibodies in this particular case, and immediately, so maybe, they didn't do the appropriate typing, in which case they had a hyperacute rejection, and there's not a lot you can do for that. The second type would be, so that was hyperacute. The second type would be an acute rejection. Now, an acute rejection it sounds like it's just a couple of days to weeks, but it can sort of move out in time as well. And so what's going to mediate when we get into acute and chronic rejection tends to be a cell-mediated type immunity. So whenever you see immunopathology, you want to start thinking about can you possibly suppress a T cell-mediated immune response in order to prevent a rejection. And chronic tends, is sort of an inevitable thing. Eventually, an organ will reject. We have a family friend who's had a heart transplant. I think he's one of the oldest ones in the country, and he's had it for about 30 years. So that's quite rare, but oftentimes eventually you're going to get fibrosis. I'm not going to get into a whole lot of detail about, at what space it rejects, etc., because that's probably more for a pathology class, but this is more broad strokes. The last thing would be a unique character called Graft-versus-Host. So it's just what it says. The new guy attacks, the host. So the new organ. And this is going to happen when your host is immunosuppressed. In other words, like if you're going to do a bone marrow transplant, why would you do a bone marrow transplant? Because you have a cancer maybe of the bone marrow. And so you basically eradicated that bone marrow to where he's got really not a whole lot going as far as an immune response of any kind, because you eradicated it. And then now you got this new guy that comes into the block, and he starts killing the host, because the host has no defense. And they call that graft-versus-host. And it's specific to these cases where the patient is severely immunosuppressed prior to getting that. You're probably not going to see that with like a heart transplant, but you will see that definitely potentially with a bone marrow transplant. So with that in mind, let's look at a couple of questions. Number one is, soon after birth, your patient, a newborn, a little redundant there, undergoes a heart transplant surgery. You recommend enrolling her in a trial for a drug that is a monoclonal antibody for what? This issue, basically, you're going to prophylax. You're going to try to mitigate the chances that she's going to have an acute rejection. Okay, and in fact, most people are going to be on immunosuppressive drugs their entire life. The patient that I mentioned that's 30 years old with a heart transplant, he's got total necrosis, okay, of his hips, etc., because he's been on steroids for 30 years and they've just torn the heck out of his body. Okay, so because he's had to be on immunosuppressive. So this is asking about an immunosuppressive drug. So all you got to know is which type or which arm of the immune system do you want to suppress? And we already said it's cell mediated. So in the case of here, which one is related to cell mediated immunity, aka T cell mediated immunity? A, CD3. That's a T cell receptor. That looks good, so I'll take that one. That's the correct answer. If it was CD40L, that's, you know, it's on a T cell, but it's related to B cell isotype switching. CD18 and 11, that's adhesion. It's not as good as the CD3. And then CD20 is the B cell mediated. Again, not cell mediated. So with regard to T cells. Now, number 2 is the graft rejection you would be attempting to prevent is mediated by which of the following responses in that previous question. And that's going to be the T cell. So that's A. A is a good answer. T cell. All right. Number 3 is your patient manifests a classic case of graft-versus-host. The cells doing the damage to the implanted organ are most likely what kind of cell from what kind of transplant, and this is also considered what kind of hypersensitivity. So the answer is A. It's a donor CD4 and CD8 T cells, and it's probably a bone marrow transplant, and it's a type 4 hypersensitivity reaction. So the answer is 3. Okay. Number 4 is you're a transplant surgeon performing a kidney transplant on a 12-year-old. There's an immediate vessel thrombosis and subsequent ischemic necrosis. Not a particularly good day for this surgeon. So the most likely cause of this is what? And we go through the answers. T cells injure the graft by direct cytotoxicity and type 4 hypersensitivity. No, that's describing an acute reaction. B, anti-donor antibodies against graft antigen. Nope. C, T cell cytokines stimulate vascular smooth muscle proliferation. No, we never talked about that. D is preformed antibodies bind to the graft endothelium, and that's the correct answer. Binding to that graft endothelium, and it necroses it, thrombosis, no blood flowing, the organ, you know, turns gray and dies. Number 5 is the graft rejection in the previous question is called what kind of rejection? And that's, of course, we talked about hyperacute, which is answer number D. Number 6 is cyclosporin and FK506 are reported to switch off the gene transcription involved in activation of NF-kappa beta. Remember NF-kappa beta, that's instrumental in the signaling cascade for the inflammasome, which is going to basically take pro-caspase to caspase, and then that's going to slice and dice pro-IL-1 to IL-1 and IL-18, pro-IL-18 to IL-18. But NF-kappa beta is also instrumental in the proliferation of many other things, okay? And it's that, including IL-2, for example. And so what this particular drug does is that it's going to, you know, it's an immunosuppressive to try to suppress, to try to suppress your cytokines. So they would most likely benefit who? And this is A, patients undergoing acute renal transplant rejection, so definitely A, and then also D, anybody with autoimmune disease, okay, so because it's often cell-mediated autoimmune disease, as we talked about with regard to some of the other, you know, Hashimoto's, etc. Number 7 is if the transcription of NF-kappa beta was blocked with a decoy transfection, which of the following would also be blocked? So this kind of shows you the power of NF-kappa beta and all the different cytokines that it's going to block. So ICAM1, IL-1, TNF-alpha, INOS, MCP-1, all of those. Okay, MCP, if you remember, that's a monocyte chemotactic or chemokine that attracts monocytes. Number 8 is a targeted treatment for acute graft rejection would include anti-what? Okay, so it's single best answer. Acute, not hyperacute. Remember, hyperacute would be your preformed antibodies. This is acute, so we're thinking T cell. T cells are single digit. B cells are double digit. So T cell, the only single digit is CD3, which is going to be D, is in delta, which is the correct answer. Number 9 is patients undergoing a bone marrow transplant would benefit from which of the following? We covered this a little bit before with regard to cancer, where they have their bone marrow is destroyed because those cells are being killed by your chemotherapy, rapidly proliferating cells. This is a slightly different variation, but the same drug. And the answer in this case is going to be D, which is the granulocyte monocyte colony stimulating factor. So that's going to enable your little guys to sort of fight back in the event of a graft-versus-host type of a reaction, and to certainly improve the status of the patient's immune system. Thank you very much.